Hi, and welcome to Rad Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Rhea Kraft, and I am a radiation oncologist based in New Jersey. Today, we will be starting a new series focused on contouring and plan evaluation in radiation oncology. And the first video in this series will go over how to evaluate a radiotherapy plan. In this first video, I would just like to go over some of the very general principles around evaluating a radiation plan. And once we go through kind of a structured way of approaching plan evaluation, I'll share an example case of palliative radiation to a bone metastasis and kind of walk through how I go about evaluating that plan. And then in future videos, I'm hoping to make more involved site-specific videos talking about contouring pearls and also plan evaluation specific to various disease sites. So in radiation oncology, as far as the planning process is concerned, what typically happens after a patient is seen for consult, they come in for their CT simulation, they get a CT simulation scan in the treatment position, and then the physician works on contouring, which is basically delineating the target organs as well as the organs at risk. And finally, the prescription, or when the physician is happy with their contours, they write a prescription for their planners. So they send a prescription over to their dosimetrist saying, this is the dose that I want to go to my target volume. And this is typically accompanied by a list of constraints of kind of maximum dose tolerances, whether they are maximum or volumetric dose constraints that are applied to all of the organs at risk. And then the planner works on that behind the scenes and sends a plan to the physician, back to the physician for approval. And this is really a critical step in radiation planning because the physician looks at the planner's work and determines if they are happy with what the planner has done, if they have kind of achieved what the physician was hoping they would achieve, or if there might be some necessity for a little bit of back and forth to tweak certain things. Sometimes it's better to prioritize an organ constraint versus target coverage, and vice versa. Sometimes it's better to prioritize target coverage over a particular organ constraint. So this step of plan evaluation is after the physician has completed contours, after the dosimetrist has worked on the plan. They typically send the plan back to the physician, requesting approval. And this is where, this is what we'll be focusing on this video, which is where the physician kind of goes through evaluating the plan and making sure it's safe and acceptable from a clinical perspective. So this particular screenshot is a screenshot, an anonymized screenshot of an example treatment of a left iliac bone metastasis. And this planning was done in Eclipse, which is a planning software that's attached to ARIA. There's a few other different, oncology planning softwares. I've always used Eclipse, both in residency and in my current practice. So that's what the examples will be based off of. But the general principles that we go over for how to evaluate a radiation plan can be applied, regardless of which planning software you're using to evaluate. So let's get into it and talk about the different steps that we go through for plan evaluation and what we're looking for and how we go about looking for it. So there's a really nice mnemonic that was published in Applied Radiation Oncology, and then there was an update published in Advances in Radiation Oncology. The original publication came out in 2017, and the mnemonic that was offered was FCB-CHOPS, and it kind of walked through the different steps in evaluating a radiation plan. But then in 2025, the same group kind of revised the mnemonic and improved upon it, and the new mnemonic that's recommended is FCB-CHOPS. And on the right-hand side of this slide, I've kind of written out what each of those letters stands for. So what we're going to do is kind of one by one walk through each letters of this mnemonic and just kind of talk about what we're looking for, what it means, and then at the end we'll go through an example of a palliative case and kind of apply this mnemonic in practice. And again, I don't want to take any credit for this mnemonic. This was published by a group of radiation oncologists that wanted to make plan evaluation a little bit more accessible for trainees. And I really, really appreciate it. I would highly recommend you check out the original papers that are cited here. My goal is to really just kind of summarize this literature and try to, help make this mnemonic more accessible and kind of walk through how it would be used in an example case. So FCB-CHOPS, let's get started, go one by one through the letters and talk about what each of them stands for and what we're looking for. So F stands for fusion. And when we're evaluating any radiation plan, the first step is to back up and make sure that our contours are based on something that makes sense, right? And the very first step before we even begin contouring anything is to make sure that the necessary images are fused correctly. So you need to ask yourself, what are the necessary images that need to be fused? Are they fused? And then is that fusion accurate? So to give you an example, if you are contouring anything in the brain, you need to have an MRI to be able to see the contrast in the soft tissue in the brain, right? So you can't see brain tumors very well on a CT scan. So you need to have a brain MRI without contrast. And that brain MRI should be really precisely fused to your CT scan that you use for planning. If you're contouring a tumor in the lung or an esophagus tumor or an anal cancer, most of the time you'll have a PET scan that you use and you kind of fuse that PET scan to the CT scan and make sure that it's correctly fused. And when we're fusing these images, we really need to pay attention to what area needs to be properly lined up, right? Because when a patient gets a PET scan, they're typically laying on a radiology scanner and they're going to be laying with their arms down and their neck might be in a different position or their arms might be in a different position than the position that they are in at the time of radiation. So we often have to make, sacrifices as far as fusions, or sometimes we even have to make multiple fusions if we're looking for targets that are slightly far away from each other. So you just need to make sure that the fusions make sense. You have the appropriate images fused. The next step is to double check your contours. Make sure that the target volumes are accurately contoured and also make sure that the OARs are accurately contoured. Now, this step, the fusion and the contours, when you're working on your own plan, you'll probably do this step and double and triple check things before you even submit the contours to your planner for planning. But if you're evaluating another physician's plan, it is important to check the fusion and the contours. And also if you're evaluating your own plan and maybe it's been a day or two since you worked on it and you're not fully remembering, it never hurts to double, triple check these things. So when we're checking the contours, target volumes are going to be important. It's very important to make sure that the target volumes make sense. And that's something that, you'll get a sense of as you get better at contouring different disease sites and practice evaluating different plans during your training. But you really want to make sure that the targets are accurately contoured. Look at the gross target volume, the clinical target volume, the planning target volume. Does it look like the margins are reasonable? Does it look like the right areas are covered? And then for the organs at risk, this is really important too, because let's say you're treating a lung cancer and you're treating a lung tumor that's somewhere in the level of the thoracic spine. And if you have not contoured your spinal cord all the way through, if the spinal cord kind of cuts off just above where your actual volume is, then you're not going to accurately calculate the dose to the spinal cord, and you're actually going to maybe miss some of the cord, and that's how you make, really grave errors and end up giving too much dose to the spinal cord because you didn't properly contour the organ at risk. So spinal cord is an example of an organ where we typically apply a maximum dose constraint. So it might not be important to contour the cord the entire way through from the bottom of the skull down to the L1, L2 level in adults, but definitely in the area where we're treating, usually with at least a 2 to 3 centimeter superior and inferior margin, you definitely want to have that cord contoured. Now, if you're contouring a structure and you're applying a volumetric constraint, say something like the bladder or even the stomach or the lungs, if you're applying a volumetric constraint, then it doesn't matter what area you're treating, you really should have the entire organ contoured because you're trying to limit the dose to a particular percentage of that organ. So just making sure that all of the organs at risk that need to be thought about are contoured and making sure that they are accurately contoured so that you are accurately calculating the dose that they are receiving. That brings us to B. So we're now at FCB. And beams is the first thing that you'll really look at in your plan evaluation software, which is the beam arrangement. So there's different types of beam arrangement depending on what type of plan you're doing, right? So if you have a 3-dimensional plan, you might have a limited number of beams. You might have a 3-field plan or a 4-field plan or something like that. If you're doing IMRT, if you're doing static IMRT, you might have several different beams. If you're doing VMAT, you might have arcs, either full arcs or partial arcs. So whatever that beam arrangement is, pay attention to what the beam arrangement is and make sure that it makes sense. So if you're treating something palliatively in the right lung, ideally, if you're using 3-dimensional planning, all of your beams will come in from the right side of the patient, right? Because the highest dose is going to be wherever those beams are entering, and then there's going to be a smaller amount of exit dose. So you will have some exit dose through the contralateral side, but you definitely don't want to have entrance dose through the contralateral side. So let's say you're treating something in the right lung. You don't want to have a beam shooting through from the left side of the lung, going through the heart just to get to the right lung. Ideally, you would kind of keep all your beams tight around the right side of the patient. Same thing applies for, say, a breast cancer if you're using tangents. Typically, we use oblique tangents to treat the breast, and we try not to have our medial beam entering so that it cuts through the contralateral breast. We want to be really close and kind of avoid as much contralateral breast as we can. So look at the beam arrangement when you're evaluating the plan. Make sure that it makes sense. Make sure that you're not having beams that don't make sense or going through organs at risk and unnecessarily treating them when they don't make sense. And, some of this also goes back to your simulation setup and how things are at the time of simulation. You want to make sure that if you're treating something in the chest, for example, you don't have any beams mistakenly going through the arm or something like that. Ideally, that patient would just be positioned with their arms up so that arms are out of the way. So just kind of looking at the patient setup, looking at how the beams are entering the patient and making sure that they make sense. And then, after we evaluate the plan, and even before we evaluate the plan sometimes, our physics team does checks to make sure that the way that the beams are is not going to lead to any interference or any collisions, because sometimes just with the mechanics of how things are set up in a room based on, the patient habitus, where the beam needs to be coming from, it's possible that there could be some collisions or some ways that are like logistically challenging. So we do have quality analysis from our physics team to make sure that that doesn't happen. The second C stands for coverage. And by coverage, we really are looking at the target coverage. We're asking ourselves, is the target adequately covered with our prescription dose? Are we happy with how much of the prescription dose is being delivered to our radiation target? So typically when we're evaluating a plan, we prescribe dose to the PTV because that's the planning target volume that accounts for all of our, GTV, CTV margin, and then an additional margin that accounts for day-to-day setup error. So both intrafraction and interfraction motion. That's our PTV volume, and that's what we typically prescribe the dose to. So we typically evaluate the coverage to our PTV. And very often when you're prescribing a dose, so say you're prescribing something palliative, you're prescribing 30 gray and 10 fractions to a bone metastasis. Typically, the coverage that we're looking for is something like 95% of the PTV volume should receive at least 95% of the prescription dose, or sometimes we look for 95% of the PTV should get 100% of the dose. So if we are doing something palliative, or if we're doing kind of a conventionally fractionated radiation plan where we're doing a lot of elective nodal coverage or something like that, often we're looking for a 95-95 coverage, meaning 95% of the PTV gets 95% of the prescription dose or higher. But if we're doing a SBRT plan, or we're trying to do something more targeted, or it's some type of curative treatment where we really want to make sure that we're fully covering our target volume, we might say that we want at least 95% of our PTV to get 100% of the dose. And coverage is something that always is kind of on a seesaw with our organ at risk constraints. So depending on the clinical scenario, sometimes you have to sacrifice a little bit of coverage to meet an organ at risk constraint. Sometimes you have to sacrifice an organ at risk constraint in order to meet the coverage. And those decisions are really based on clinical judgment. What is the goal of your treatment? Is this kind of a curative case, or is this more of a palliative case? Those questions kind of fall into that. But the way that we evaluate coverage can be both visually, by kind of just looking at the dose the way it is on a patient and scrolling through the scan. And we can also look at our dose volume histogram and see how much of the volume is getting how much of the dose. And this is where on the DVH curve, that dose volume histogram, we want our target volumes to kind of be in the upper right corner of that graph. So we'll look at examples of this a little bit later and kind of show you what I mean by that DVH curve. But coverage, we really want at least 95% of our PTV typically to get 95 to 100% of the dose. And then depending on the scenario, we might be willing to accept less coverage, something like 90-90 or even 85-85, just depending on what the scenario is. H stands for heterogeneity, and it can also stand for hotspots. So heterogeneity and hotspots kind of go hand in hand with the coverage. So when we're talking about heterogeneity, one of the biggest things that we look for are the hotspots, right? So when you get a radiation plan, you're never going to have a perfect plan where 100% of the PTV is getting 100% of the dose and it's all evenly spread out. Just because of the way that radiation beams interact with the body and the way they penetrate through the body, you're never going to have that situation where it's a totally homogeneous plan, 100% of dose is going everywhere. There's always going to be hot spots. There's always going to be cooler spots as well. So as far as the hot spots are concerned, we want to make sure that they are within reasonable limits. And this is going to depend, what is defined as a reasonable limit really depends on how homogeneous versus how heterogeneous we want our plan to look. So to give you an example, when we're doing breast radiation, we're treating the whole breast, we typically want these plans to look very homogeneous, meaning we're hoping to cover the entire breast, bathe the entire breast in a relatively equal dose of radiation. Because of the physics of how beams enter the body, we know that we're going to have some hot spots and some cold spots, but overall, we want it to be as similar across the board as possible. So that is what we call a homogeneous plan. So a homogeneous plan, your hot spots would not be very high, right? Because if your prescription dose is at 100%, a reasonable hot spot for breast cancer would typically be somewhere between 105 to 110%. If we had beyond a 110% hot spot, then that's a little bit too heterogeneous, right? We typically want most of our breast to be getting somewhere between 95% to 105% of our prescription dose. So that is what I would call kind of a homogeneous looking plan. With SBRT, however, say you're treating a brain tumor with stereotactic radiosurgery, SRS, or even SBRT if you're treating a lung tumor or something like that. These plans are plans that are purposefully designed to be extremely heterogeneous. So in these heterogeneous plans with stereotactic radiation, conversely to what our breast cancer plans look like, we actually want to drive the hotspot higher. And lung plans will often have hotspots as high as 120 to 130%. Even brain tumors, if you're treating them on a LINAC with SRS, you'll often have a hotspot somewhere along the lines of 120 to 130%. And the idea is that you're creating a very sharp dose fall off, but you're really driving the central dose to that target to a very high level because your goal is to ablate the tumor that you're treating. So whether or not you want the dose to be homogeneous or heterogeneous really depends on the clinical scenario, what technique you're using, what type of treatment it is. And part of that question of evaluating the heterogeneity level is evaluating the hotspot and making sure that it's reasonable. So, typically for plans where we're looking for more homogeneous coverage, so think breast cancer, think, anything that's using conventional radiation, typically if we're doing elective nodal coverage to the pelvis, even if we're treating like a lung cancer case with conventional radiation, typically that hotspot is kept less than 110% for those types of plans. But then for plans where we're doing stereotactic radiation, we typically want there to be a hotspot that's higher, so somewhere on the order of 120 to 130%, and we're actually looking for a more heterogeneous plan. Once we've looked at the target and evaluated its coverage and the hotspots within the target, it's time to turn our attention to the organs at risk. That's abbreviated as the OARs. So one of the questions you have to ask yourself is, are the OARs adequately contoured? And that goes back to the original C where we talked about contouring. And then you also want to evaluate the dose to the different OARs. So we talked previously about how on the dose volume histogram, the target volumes should typically be in the upper right-hand corner because we want a high amount of those target volumes to be getting a high amount of dose. Typically, our organs at risk are going to be in the lower left-hand side of that graph because we want a lower volume of our OARs to be getting any amount of dose, and we want to minimize the dose to the OARs as much as possible. So one of the most important things to think about is, are those OARs accurately contoured? And if we're using a maximum dose constraint, then it's okay if the entire structure is not contoured. It should just be contoured within a reasonable superior and inferior margin of where our target is. But if we're using a volumetric constraint, especially a percentage dose constraint, then we definitely want to make sure that the entire volume of that organ is contoured, such as the lungs or such as the liver. And the way that we evaluate the dose to the OARs is typically in our dose volume histogram section. And there's also a dose statistics section where you can see the maximum dose as well as the mean dose to your different organs at risk. So whatever dose you tolerate for organs at risk will typically be defined depending on the protocol that you're using. Quantec dose constraints is something that you can Google, and that gives us a nice general baseline of how much dose is acceptable for various organs at risk and what percentage risk of toxicity that's been linked to. But again, these are often clinical judgment calls based on the clinical situation of whether we want to prioritize the OAR constraint or whether we want to prioritize the coverage. But whatever organs at risk are critical, you always want to make sure that you're identifying those and evaluating the dose to those organs at risk and making sure that it is safe. The P stands for prescription, and in the plan evaluation module, you definitely want to make sure that the prescription that you have indicated is the prescription that the plan was designed to deliver, because you definitely don't want a situation where you prescribed 30 gray in 10 fractions and your planner decided to give 20 gray in 5 fractions and there was a miscommunication or something like that. So you always want to double check the prescription. And I know this is the second to last point in the mnemonic, but checking the prescription is one of the first things that I do when I'm evaluating the plan, because you just want to make sure that the prescription is accurate, you're giving the right amount of dose. You want to make sure you didn't put in an extra zero somewhere and, make it a life-threatening dose rather than the actual prescription dose you wanted to give. So just making sure that the prescription dose is correct is very, very important. And then finally, the S, which is new from the 2025 publication, stands for the summation of dose. And this is something called a plan sum that is created if there are multiple radiation treatments that are being delivered. So if the patient has a prior history of radiation to an overlapping field, it is really best practice for the dosimetrist to create a plan sum where they combine the dose cloud from the patient's previous treatment or treatments with the current treatment that is being delivered. And evaluating multiple treatments and how much dose is safe to give is a very tricky process because, as we know in radiation oncology, the dose per fraction is extremely important. So if you're comparing an old plan that got 30 gray in 10 fractions with a new plan that's getting 20 gray in 5 fractions, the total dose to the organs at risk is not as simple as saying it's 30 gray plus 20 gray. And when a plan sum is created, typically softwares are not able to convert it to an equivalent dose in 2 gray per fraction. They typically will just sum the total dose. So it'll show you what 30 gray plus 20 gray looks like. So it's really the physician's job to kind of think about what that means as far as the equivalent gray in 2 gray per fraction. But it is really best practice to make sure that a plan sum is made, make sure you're evaluating where the hotspots are the highest and if those areas are safe, if the dose tolerance there is safe. But it's really best practice to create that plan sum if you're treating multiple overlapping fields. So now that we've walked through the FCB-CHOPS mnemonic, let us apply this mnemonic to an example case. Say that we're treating a bone metastasis in the right humerus to a palliative dose of 20 gray in 5 fractions. So the first step, remember, that we want to do is check the fusion. And in this case, because we were treating the right humerus, the patient was simulated with their arm sort of akimbo. And whenever you're treating any extremity, it does make a little bit of sense to have the arms akimbo just so that the target is kind of away from the body. It's also nice to have something asymmetric that can kind of help ensure that you're treating the right laterality as well. So the right arm was treated akimbo, and for this patient, we actually fused a PET scan too. So the image that we're looking at looks a bit wonky, but that's because the CT scan from the simulation, you can see the body contour outlined in green, was done with the arm akimbo. The PET scan, the patient had their arms at their sides. So we actually, when we did the fusion, we focused the fusion on that right humerus, and we had to kind of shift how the patient was oriented in the PET scan to line up the humerus with how the humerus was oriented at the time of the CT sim. So that's just an example of focusing your fusion on the target that you're interested in. So this example is a PET scan, but the same principle applies. So if you're treating something in the cerebellum, for example, when you're doing your fusion, you want to make sure that it's really good right in the cerebellum. So if there's a bit of rotation, superiorly in the cortex or something like that, you're not as worried about it because your target is in the cerebellum. So same principle applies here. We're treating the right humerus. We focused our fusion specifically on the right humerus. And then the next step is to evaluate the contours. So I don't have a specific picture for this. There wasn't much to contour for this because it was just a bone metastasis in the right humerus. So we really just created a clinical target volume that included all the area in the bone of the humerus that was avid on the PET scan, plus a little bit of extra margin on the normal bone around that area. And for that, we added an additional, probably a 7 millimeter margin just for the planning target volume, and that became our target volume. And at this palliative dose of 20 gray in 5 fractions, and also given the location, there's not too many organs at risk that are concerning in that area. So it was really just focused on the target volume. So the next step after we've looked at our contours and our fusions is to look at the plan and plan evaluation. So I typically evaluate external beam plans in the tab called External Beam Planning within Eclipse. And when you click on that, within the patient, a screen pops up to open the specific plan that we're interested in. So as you can see, this patient has had 2 prior courses of radiation, and then they now have a third course of radiation to the right humerus. So the prior two courses were not anywhere near the right humerus, so we didn't really need to make a planned sum. But in external beam planning, we can pull up just the right humerus plan. We can also click on all three plans and open them all up to see all the different places that the patient has been radiated. So in this case, we can open up all the plans, but we're really just going to be looking at the right humerus. So once we open up the right humerus plan, on the left side, on the top box, you can kind of see the courses listed out and you can see the plan. So underneath that RX box, you actually have to click and drag the right humerus plan and pull it in. And then you also can see on the box that's on the bottom on the left-hand side, there's kind of a scroll bar there. So that scroll bar allows you to scroll through, select different structures that you've contoured. So in this case, we would be interested in selecting the PTV for the humerus because that's our target. And then, at the bottom, there's that horizontal box with a lot of different click-through options. There's different tabs that you can click, fields, dose, field alignments, etc. And then the four boxes in the middle, you have your coronal, axial, and your sagittal views of the plan itself. And then on that upper right box, we have the ability to kind of look at, different views, the 3D view of the beams on the patient. There's DVH, which if we click on that, we'll actually get to see the dose volume histogram. And then you can also look at the beam's eye view, so what the entry of the beam looks like on the patient as well. So this particular layout, whatever first pops up when you open up the plan, is quite overwhelming because it's like everything is highlighted. You see all these different isodose levels, and it's tough to make heads or tails sometimes of what you're looking at. So it's good to have a nice systematic way of going through. So we did the fusion, we did the contours. Now what we want to first look at is the beams. Does it make sense how the beams enter the patient? So in this next slide, you can see that I made some changes to specifically evaluate the beams and how the beams enter the patient. So if we scroll down on the left-hand side, earlier in the previous slide, we kind of had a screen where we were looking at all of the different structures that had been contoured. In that same window, if we scroll down, we have some additional things that we can click. So we can click off the dose just for the time being, and we don't need to think about the dose distribution. And let's just look at the fields. So under the fields section, your dosimetrist will have kind of the main fields that are being used to treat the patient. And then they'll also have some imaging fields that are set up. So they have, you can tell it's a PA setup, a DRR, a right lateral setup, DRR, and then there's also a cone beam CT setup, DRR. And then they actually have the treatment fields that are delivering radiation dose, and you can tell because they have a different symbol next to them. So I unclicked all of the fields except for the two fields that are actually being used to deliver the dose. And these fields are now the only fields that are highlighted, and what we can tell by looking at them is that this is a plan that's being delivered using an APPA beam. And we need to ask ourselves, does that beam entry on the patient's body make sense? And to me, an APPA setup for right humerus makes a lot of sense because now your dose is just entering and exiting through the patient's arm. There's no need to have a lateral beam coming in through the right arm of the patient because if we had a beam coming in laterally, it would have exit dose through important structures such as the lungs and the spinal cord, and we don't need that. We don't want that. So an APPA setup makes a lot of sense. It might make sense to treat a bony metastasis with kind of a 4-field plan with 2 anterior and 2 posterior obliques at times, sometimes just 2 posterior obliques and 1 anterior field. Again, depending on where in the body you're treating, different field setups might make sense. But for something so basic such as a right humerus met, APPA is perfect. So I am happy with that beam. So now we've looked at F, C, and B, and now it's time to look at the actual kind of dose, coverage, heterogeneity, hotspots, OARs, and the prescription. So that's kind of the CHOP part of the mnemonic. So this part I don't always do in order. The first thing that I typically look at once I've confirmed the beam alignment is I look at the prescription. And so you can see when I just changed the slide, I went from clicking fields on that tab on the bottom to the dose in the tab on the bottom. And now the bottom screen, the bottom part of the screen shows something different than what the fields showed previously. That now shows us the dose that was prescribed. And you can see that for the right humerus, we are prescribing 20 gray or 2000 centigray in 5 fractions. So we're delivering 4 gray or 400 centigray with each fraction. And that is in line with the prescription. And then this brings us to looking at the coverage, heterogeneity, and OARs. Now, OARs, for this plan, we really did not look at any OARs just because there's not any critical structures at the dose level that we're going to in this area. So OARs, we can kind of put that aside until the future when we look at other plans where there are actually OARs of interest. But besides just the prescription, we definitely want to look at the coverage and the heterogeneity. So as far as coverage, typically the first thing that I do to evaluate coverage is I just look at things visually. So I still kept the fields on, but now I clicked back the dose, and you can change the settings so that instead of just looking at the isodose lines, you can also change it to this color wash view. And you can also select if you want to look at the percentage, which is relative to your prescription dose, or if you want to look at just the absolute dose, which in this case, we're looking at the absolute dose in centigray, which is 2000 centigray. And I've turned on the dose color wash to show me what 2000 centigray looks like. And when we're looking at this color wash, the blue represents whatever is getting 2000 centigray, and that gradient of color moving towards red represents the hotter spots within that dose cloud. So you can see, where the hot spots are by kind of looking at the red blotches that are within that color wash. And you can also tell how much the hot spot is. If you look in the upper right-hand corner of this image, there is some text that says the 3D dose max is 2092 centigray. So we can also look at that as a percentage. And here on this image, I've sort of shifted to a beam's eye view, and I've changed from showing you a dose color wash to kind of percentage levels. And the 3D dose max that corresponds to is 104.6%. So that's less than 105%, and I think that's an excellent hot spot for something palliative like this. I probably would have accepted a hot spot up to around 108 to 110% if needed, but I'm very happy with a hot spot of less than 105%. And this beam's eye view is kind of showing you the entry of the AP beam on the patient's skeleton, and you can kind of see the yellow box is where the jaws are closed. You can see the X and Y jaws. And then all of those blue lines reflect the MLCs, and you can see how inside of the jaws, the MLCs are brought in further to kind of nicely shape our beam to the contour of our target volume. So we've now looked kind of visually at the coverage, and we've also identified the hot spot, which is 104.6, and putting that together with what the dose looked like visually, we can tell that this is a pretty homogeneous plan. And that's what we want for something that's palliative like this. And then finally, we have the dose volume histogram. So I clicked on that DVH tab and I enlarged the graph that shows up. And with the DVH, we really can look at both the target coverage as well as organ at risk constraints. And in this case, there were not any concerning organs at risk, but we do have the PTV for the right humerus, which is our target that we're interested in. And we can see that the dose volume histogram for this is very nicely in that upper right-hand corner, which is where we said we wanted it. and we can see that the volume of the tumor, which is on the y-axis, getting the maximum or the prescription dose, which is 2000 centigrade on the x-axis, if we trace that line up, we can see that over 95%, probably something like 98 or even 99% of our PTV is getting that full prescription dose of 2000 centigrade. So this is really excellent coverage. So we have now gone through, FCB, we've gone through coverage, heterogeneity, organs at risk, we said did not really apply. We did check the P for prescription. And then plan sum, they did create a plan sum, but the prior course was to the left humerus, so I'm not going to show the plan sum because it really doesn't overlap very much because the left humerus was also treated with APPA. But, if we had an overlapping site, it would be very good to look at that plan sum. The very last screen I want to show is back to one of the first images that I showed and looking at the plan. And you can see that in the bottom of the diagram, we're back to the fields tab. And if we look at the list of fields that are listed, we see the 3 different imaging setups. So we have our PA, our right lateral, and our CBCT setups. And then we also have our AP and PA fields that are actually delivering the radiation. And if we kind of look horizontally at those fields, we can see that one of the fields is using a 6x beam, so that's a 6 MV beam. And then the other beam is using a 10x beam, so a 10 MV beam. So we're using mixed energies. And then if you follow those lines and you go all the way to the right-hand side, we can see the number of MUs, which stands for monitor units. So monitor units typically tells us what the machine is delivering. I kind of think of it as how hard the machine is working. And typically machines are calibrated so that one monitor unit corresponds to a specific dose, such as usually it's something like 1 centigrade. And in physics, you'll kind of learn how to calculate the number of monitor units based on different kind of calibration factors. But standardly, typically 1 monitor unit corresponds to 1 centigrade of dose that the radiation machine is delivering. So for palliative plans that are not highly modulated, such as this one, you're basically treating with open jaws. You just have your MLCs brought in a little bit to shape the field to the target volume. The number of MUs is going to correspond almost 1-to-1 with the dose per fraction. So in this case, our dose per fraction was 400 centigrade, and you can see you're delivering 212 MU with one beam, and you're delivering 236 MU with the other beam. So that's very close to 400 MUs, which correlates very well with our 400 centigrade for the prescription. This is because this is a 3-dimensional plan, very simple with just APPA fields. If you were doing an IMRT plan or a VMAT plan with highly modulated fields, you would find that the number of MUs vastly exceeds the dose per fraction. Sometimes, on the order of like 3 times as much or something like that, just because the beam is so highly modulated. So it is nice for these palliative plans to also just be able to check back to your MUs and make sure that your machine is not working harder than it needs to deliver a very simple palliative radiation plan. So I just wanted to point out that note about the MUs. But otherwise, even if you don't remember that point, hopefully we've kind of drilled down now that mnemonic of FCB-CHOPS. And again, those checklists don't need to be conducted in that exact order every time. As I showed you, I often check the prescription first before I look at anything else. As long as you're making sure to look at all of those things, it starts to come naturally to you after a while. But it's really nice to have that structured mnemonic just to make sure that you're not missing anything. And that brings us to the end of our first video on how to evaluate a radiotherapy plan. So I hope that this overview video was very helpful, going through those papers that looked at these mnemonics. I love the mnemonic CB-CHOP and also FCB-CHOPS. I still use them to this day when I'm evaluating radiation plans just to make sure that I didn't miss anything. And I think they're excellent training tools for learning how to evaluate a radiation plan. I went through things very simplistically here, and hopefully, no matter what level you're at, this helps to kind of systematically go through a palliative radiation plan and kind of point out the different things that I'm looking for as I evaluate the plan. In future episodes, or I guess videos in this lecture series, what I'm hoping to do is get into kind of disease site specific videos where we actually go through sites like breast or lung, for example, and, kind of go through pearls around contouring the target volumes, the OARs, and then plan evaluation and talking about specific dose constraints that we look at when we're evaluating these plans. So it'll be a slow process, but I'm hoping to gradually get out site-specific videos as well. But for now, hopefully this was helpful to you. Thank you so much for your time and attention.